We will have next case of elderly lady with newly diagnosed gastric tumor. She presented with increasing epigastric pain and also tarry stool in November with an anemia requiring transfusion. Private OGD at that time showing a 5 cm tumor with ulceration but without active bleeding at the cardia, and the pathology is ulcer debris. Another contrast CT was done showing a large 13 times 12 times 14 cm soft tissue mass with contrast enhancement in the epigastrium extending from the pancreas and also eroding into the gastric body. Here is the CT images for the tumor. So today we will have contrast enhanced EUS and also FNB with POCOR.
This case have huge mass in the space between pancreas body and tail and the gastric wall. So I inserted my echo endoscope. Generally, I use linear echo endoscope. These days, I seldom use radial scope. The linear scope, we can do imaging and we can do biopsy. Most of the functions are available. So my nurses never give me radial scope, just linear. Yeah, I follow that order. Now I am in the mid part of the stomach. We are looking at the liver here, left lobe of the liver.
Yes.
If I rotate posteriorly, then I may see some of the pancreatic tissue. I guess this area is quite suspicious for pancreatic tissue. But if I rotate a little bit more, then suddenly this mass comes into view. This is huge mass. And inside there is some cystic cavity and some blood flow, and the echogenicity is quite heterogeneous. This is a very large lesion. To this lesion, we need to adjust the penetration. And if we measure the dimension, probably from here to here is more than 11 cm.
Yeah.
So a very large cystic, large and huge mass. And if you see just this plane, then it looks like it is located outside of the stomach. This is a gastric wall,
Yeah.
and this side also gastric wall. But the main region is located outside of the gastric wall. So may look like a pancreatic or retroperitoneal lesion. But if we trace this lesion a little bit more, we can see a little bit of pancreatic tissue here, and splenic vessels are here. I'm trying to trace the lesion. Suddenly we can see another hypoechoing mass here, and also here, and here. These are all masses. If you just focus on this near side mass, I think everybody probably agree that this lesion actually connected with the muscular layer of, not this side, on the other side. Yeah. If you see this area,
Yeah.
it is connected to proper muscle layer of gastric wall here. And if we trace this lesion a little more by talking, then this lesion is connected to the outside mass here. So the lesion actually started from gastric wall, and it shows exophytic growth to the extra-gastric cavity. And also, this lesion showed, in the meantime, I did some examination, and this lesion also showed intra-gastric protrusion too. So just a moment, yeah. If I go, a little bit, This is gastric PM. Here we can see gastric PM goes like this, but this part shows intra-gastric protrusion. So this lesion upon CT scan may look like the pancreatic mass, but it is really originated from gastric wall, probably muscular layer, and then showed intragastric protrusion and also extragastric protrusion too.
So it's likely a cyst.
Yeah, likely a huge cyst. So Any comment or question on this?
So Dongwan, how do you assess if, obviously this lesion is very large, but
Yeah.
are there any other features that is suggestive of malignancy? Yeah.
One is the size is also one of the criteria. If it is more than 5-6 cm,
Yeah.
the probability actually increase.
Definitely.
This is already 12 cm,
Yes.
around 12 cm, so hugely. And another feature is the echogenicity, homogeneity of the lesion. Generally, benign cyst or leiomyoma shows homogeneous echogenicity, but in this case, there are some necrotic, unechoic area, and also increased and decreased echogenicity, heterogeneous, mixed pattern. This pattern also suggests the possibility of malignancy. And if you do contrast enhanced, I think generally cyst shows homogeneous enhancement if it is benign. But if it is malignant, there will be unechoic necrotic area and the enhancing area mix up. So I think if we add, we can get a little more information on this. So can we inject some contrast to see the contrast enhanced EUS?
Since Anthony is here, I'd like to ask you as a surgeon, would you take a biopsy and hopefully give some adjuvant therapy, or you go straight ahead for surgery?
Yeah, this lesion is quite big, and there's some the lesion. We also worry about some adjacent organ involvement, like the pancreas and so on. So, I think for such a lesion, we often would consider a adjuvant Gleevec and try to shrink down the tumor a bit before moving on to a surgical resection.
Oh, so
I
you
think
do
the
biopsy.
Yeah, we will do biopsy, but before that, we want to characterize this lesion by contrast enhanced EUS first, and then we will proceed to biopsy.
Okay.
Now contrast is ready. We are going to use a second generation sonoview here. Okay, inject, and then if you want to see the just enhancing pattern, we need to gain a little bit down, and enhancement paths generally start from 20. You see the contrast is going inside here, but there are tumor vessel traversing, but some area shows this kind of well enhancement, homogeneous, but this part, but this area does not show good enhancement. As I mentioned earlier, there is mix-up of homogeneously enhanced area and non-enhancing area. This picture also suggests this lesion is probably malignant lesion.
So you would say this is heterogeneous enhancement, right?
Yes, heterogeneous, mixed enhancement. And the tumor vessel is very strong. I think for benign lesions, we cannot see this kind of very strong tumor vessel and big tumor vessel. But in this case, we can see quite large tumor vessel. So every finding is suggestive of malignant cyst. But histology is anything cannot replace histology. So we better to do EUS guided biopsy. If you start from linear, we can do everything. Evaluation, contrast, and also biopsy too. Now this time, because for GIST, we need to get a larger tissue amount if you want to add the immunohistochemical staining. So for this purpose, I'm going to use 20 gauge Procore C needle, which is recently launched from a cool company. Can you show it? And
Okay.
explain
So this is the Procore needle. It's a 20 gauge needle. It's a new Procore. So as you can see, there's a forward baffle. In the previous version, there's a reverse baffle, and it came with 19, 21, and 25 gauge. But now they've changed it into 20 gauge forward baffle needle. So nowadays, we are also asking our pathologists to not only do the immunohistochemistry, but at the same time, we also ask for even for mitotic activity. So it's possible.
Generally, I use my standard needle is 22 gauge needle, but this is 20, so a little bit thicker than usual needle, but it shows a pretty good flexibility. But one thing we need to be careful is this is relatively thicker needle, so you can, if this needle punctures the vessel, then the field will be very bloody. So try not to puncture the vascular, highly vascular area.
Would you want to
So-
puncture in an area where the lesion is connected to the stomach, or?
I think this one is okay. Do you want to do? Do you want to target the intragastric area?
Yeah, I think in terms of surgical principle, we usually try to resect
okay.
where it's connected to the stomach. So maybe that's better to avoid tumor seeding in the future.
Yes. Okay, I will follow your instruction. Mm. This is intragastric part.
Yep.
Here.
Mhm.
Mhm. Now we'll check the needle position first
Mhm.
and deflate the balloon a little bit,
Mhm.
and then try to target
Okay.
the lesion. But it is intragastric part is not very stable.
Okay.
Mhm. Mm. It goes outside of the gastric wall. This part.
Or maybe where
I
the,
think
yeah,
better to target
yeah, maybe the area where there was sort of
yeah, and also the vascularity
Yeah.
is one more. The angle and position is not stable,
Yep.
and the vascularity.
Okay. So you target the extra gastric.
Yes, extra gastric part. This part
Okay.
is quite stable,
Yeah.
and before needle puncture, we will check the vascular and the non-vascular area. The E-flow function is quite useful to check because E-flow can depict some of the microvessels. So I think that this area can be a good target.
Yeah.
Mhm. This one?
Okay.
Yeah, okay. So I'm going to puncture from this. This is a necrotic area, so better to avoid this necrotic area, but rather solid area. Okay, now we are going to apply slow pull method while I'm doing to and pro motion. 1, 3, 4, 5, 7, 8. But I don't like this slow pull. Many people say that it gives adequate sample, but frequently does not give any sample. Okay? Okay, I think it's okay. Now I'm going to remove the stylet and fix it and remove it.
Right. Thank you very much. It's a very good demonstration of fine needle biopsy.